Good day and welcome back to my channel. Today I'm going to talk to you about obesity. Obesity is a public health crisis globally, with the prevalence increasing rapidly. Obesity is a complex disease involving an excessive amount of body fat. Obesity isn't just a cosmetic concern. It's a medical problem that increases the risk of other diseases and health problems such as heart disease, diabetes, high blood pressure, and certain cancers. There are many reasons why some people have difficulty losing weight. Usually, obesity results from inherited psychological and environmental factors combined with diet, physical activity, and exercise choices. The good news is that even modest weight loss can improve or prevent the health problems associated with obesity. A healthier diet, increased physical activity, and behavior changes can help you lose weight. Prescription medications and weight loss procedures are additional options for treating diabetes. I hope to achieve three objectives today. First, to describe the clinical presentations of obesity. Explain the long-term complications that stem from poor weight management. And thirdly, to describe the principles of pharmacotherapy in obesity management. Let's start with some pathophysiology of obesity. Adipose tissue undergoes a continuous remodeling process that normally maintains tissue health, but may spin out of control in obesity and lead to adipocyte death with the recruitment and activation of macrophages and systemic insulin resistance. So in obesity, there are dynamic changes in adipocyte and immune cell turnover, angiogenesis, and extracellular matrix remodeling to regulate the functional integrity of the tissue. In obesity, the macrophages are recruited. They surround dead adipocytes and polarize towards inflammatory phenotypes. Adipocytokine is a general term for bioactive product produced by adipose or fat tissue. Adipocytokines include inflammatory mediators, angiogenic proteins, and metabolic regulators such as adiponectin and leptin. Although several classifications and definitions for degrees of obesity are accepted, the most widely accepted classifications are those from the World Health Organization based on body mass index. Body mass index is also known as Quetelet index. To calculate BMI, simply divide weight in kilograms by height in meters squared. The WHO designations are as follows. One with BMI of below 18.5 is considered underweight, while those in between 18.5 to 24.9 are considered normal. A reading of 25 to 29.9 is considered as overweight, and as the value increases to 30 and higher, one is considered obese. There is a category grade 3 overweight, commonly called severe or morbid obesity, which occurs when BMI is equal or more than 40 kilograms per meter squared. The term overweight is puristically defined as an excess of body weight for height. Obesity represents a state of excess storage of body fat. Some authorities advocate a definition of obesity based on percentage of body fat. In men, percentage of body fat greater than 25%, with 25% being borderline. In women, percentage of body fat greater than 33%, with 31 to 33% being borderline. Although similar, normal healthy men have a body fat percentage of 15 to 20%, while normal healthy women have a percentage of approximately 25 to 30%. A person's body fat percentage can be indirectly estimated using the Nuremberg equation. Body fat percentage equals to 1.2 times BMI plus 0.23 times age minus 10.8 times the sex minus 5.4, with age being in years and sex being designated as 1 for males and 0 for females. Other indices used to estimate the degree and distribution of obesity include the 4 standard skin thicknesses, i.e., subscapular, triceps, biceps, suprailiac, and various anthropometric measurements, of which waist and hip circumferences are the most important. Dual energy radiographic absorptiometry (DXA scanning) is used primarily by researchers to accurately measure body composition, particularly fat mass and fat-free mass. It has the additional advantage of measuring regional fat distribution. However, DXA scans cannot be used to distinguish between subcutaneous and visceral abdominal fat deposits. The current standard techniques for measuring visceral fat volume are abdominal CT scanning at L4 and L5 and magnetic resonance imaging (MRI) techniques. A simpler technique using bioelectrical impedance was recently introduced. However, these methods are limited to clinical research. Patients who are overweight and obese experience severe COVID-19 symptoms. Obesity increases the risk of developing severe symptoms if you become infected with the virus that causes coronavirus disease. People who have severe cases of COVID-19 may require treatment in ICU or even mechanical assistance to breathe. In addition, individuals are at increased risk for a range of health conditions, including metabolic syndrome, type 2 diabetes, hypertension, dyslipidemia, coronary heart disease, osteoarthritis, stroke, depression, non-alcoholic fatty liver disease, infertility and erectile dysfunction in men, risk of stillbirth, gallbladder disease, obstructive sleep apnea, gastroesophageal reflux disease, some cancers like endometrial, breast, and colon, as well as asthma. At minimum, test fasting cholesterol, triglycerides, and high-density lipoprotein cholesterol (HDLC) levels. These levels may be normal or the typical dyslipidemia associated with cardiometabolic syndrome may be found. Dyslipidemia is characterized by reduced HDLC and elevated fasting triglyceride concentrations. However, increased LDL-C and normal to marginally increased total cholesterol are also common among obese individuals. Liver function tests yield normal results in most obese patients. However, elevated transaminase levels may indicate non-alcoholic steatohepatitis or fatty infiltration of the liver. Thyroid function tests results are also typically normal, but checking them to detect primary hypothyroidism, characterized by increased serum thyrotropin and normal or reduced thyroxine and/or triiodothyronine levels is worthwhile. Of importance, hypothyroidism itself rarely causes more than mild obesity. Obesity is associated with insulin resistance and increased serum levels of fasting insulin and C-peptide serum levels. However, insulin levels are normal in many persons who are obese. All patients with obesity should be screened for diabetes. Additional information is gained by using glucose and HbA1c tests together if the patient is fasting. Prediabetes is indicated by impaired fasting glucose, i.e., fasting plasma glucose levels of 100 to 125 mg per deciliter, or 5.6 to 6.9 millimole per liter, or impaired glucose tolerance, which is 2-hour oral glucose tolerance tests values of 140 to 199 mg per deciliter, also 7.8 to 11 millimoles per liter. Patients with these findings are at relatively high risk for the future development of diabetes. Type 2 diabetes is diagnosed when the fasting glucose is 126 mg per deciliter or greater, or HbA1c is 6.5% or higher. Treatment of obesity starts with comprehensive lifestyle management, i.e., diet, physical activity, behavior modification, which should include the following: self-monitoring of caloric intake and physical activity, goal setting, stimulus control, non-food rewards, relapse prevention. Diet, exercise, and behavioral modification should be included in all obesity management approaches for BMI of 25 or higher. Other tools, such as pharmacotherapy for BMI of 27 or higher with comorbidity, or BMI over 30 and bariatric surgery for BMI of 35 with comorbidity, or BMI over 40, should be used as adjuncts to behavioral modification to reduce food intake and increase physical activity when this is possible. Conventional diets can be broadly classified into two categories. First, balanced low-caloric diets or reduced portion sizes, and second, diets with different macronutrient compositions. Balanced, low-caloric diets and reduced portion sizes diets are the types that dietitians and other weight management professionals most commonly prescribe. Although these diets are useful for short-term weight loss, none of them alone is associated with reliable sustained weight loss. These diets underlie most of the popular commercial weight loss programs, such as those advocated by Jenny Craig, Weight Watchers, Take Off Pounds Sensibly, and Overeaters Anonymous. The basic premise for people on these diets involves obtaining their detailed dietary inventory and using it to estimate their mean daily caloric intake. A reasonable goal for the caloric deficit is based on the new goal for total daily calories. Meal plans are then devised to provide this total, divided among 3 or more meals throughout the day. The meals may be based on regular everyday foods. In such cases, strategies for effective reduction of portion sizes become central. Alternatively, portion control can be achieved by participation in structured weight loss programs, or by the purchase of products such as meal replacement shakes, bars, prepackaged meals, and frozen entrees. For example, Slim Fast, Glucerna, Lean Cuisine, Healthy Choice, Smart Ones. Balanced low-caloric diets or reduced portion sizes. have adequate amounts of the major macronutrients based on the food pyramid from the US Department of Agriculture and recommends daily allowances. These sources also have adequate micronutrients and trace elements. Alcohol, sodas, most fruit juices, and highly concentrated sweets are generally caloric dense and nutrient deficit, so-called empty calories. Consequently, these are generally prohibited or reduced to a minimum. As mentioned earlier, conventional diets can be divided into two: balanced low-caloric diets, which were discussed earlier, and diets with different macronutrient compositions. Now, the latter includes the following: low-fat diets, example the Ornish diet; low-carbohydrate diets, example the Atkins diet; mid-level diets, example the Zone diet, in which the three macronutrients fat, carbohydrate, protein are eaten in similar proportions of 30 to 40%. Jocelyn Y. weight diet for diabetic patients have 40 to 45% carbohydrates, 20 to 30% protein, and less than 35% fat. Patients who have a history of being unable to successfully lose and maintain weight and who meet label indications are candidates for weight loss medications. To promote long-term weight maintenance, the use of approved weight loss medication over no pharmacological therapy is suggested to ameliorate comorbidities and amplify adherence to behavior changes, which may improve physical functioning and allow for greater physical activity in individuals with a BMI of 30 or higher and at least one associated comorbid medical conditions. Example: hypertension, dyslipidemia, type 2 DM, and obstructive sleep apnea. In patients with type 2 DM who are overweight or obese, antidiabetic medications that have additional actions to promote weight loss, such as glucagon-like peptide, GLP-1 analogs, or sodium glucose-linked transporter to SGLT2 inhibitors, are suggested, in addition to the first-line agent for type 2 DM and obesity, which is metformin. In obese patients with type 2 DM who require insulin therapy, at least one of the following is suggested: metformin, pramlintide, or GLP-1 agonists to mitigate associated weight gain due to insulin. The first-line insulin for this type of patient should be basal insulin. This is preferable to using either insulin alone or insulin with sulfonylurea. ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers, rather than beta-adrenergic blockers, should be considered as first-line therapy for hypertension in patients with type 2 DM who are obese. In women with a BMI of 27 or more with comorbidities or BMI of 30 or more seeking contraception, oral contraceptives are suggested over injectable medications because of weight gain with injectables, provided that women are well informed about the risks and benefits. Few medications are available for the treatment of obesity. Examples of FDA-approved drugs that may be considered for the long-term treatment of obesity include orlistat, known as Xenical, the combinations of phentermine and extended-release topiramate, and the fixed-dose combination of bupropion and naltrexone. Generally, the medications approved by the FDA for obesity are intended for patients with a BMI of 30 or more, or 27 or more with a weight-related risk factor, example diabetes or hypertension. All are indicated as adjuncts to caloric restriction, increased physical activity, and behavioral modification. Response to therapy should be evaluated by week 12. If a patient has not lost at least 5% of baseline body weight, Stimulants should be discontinued, as it is unlikely that the patient will achieve and sustain clinically meaningful weight loss with continued treatment. Glucagon-like peptide 1 agonist. GLP-1 is a physiologic regulator of appetite and caloric intake, and the GLP-1 receptor is present in several areas of the brain involved in appetite regulation. Semaglutide. In June 2021, the FDA approved the use of GLP-1 receptor agonist semaglutide for weight loss in a 2.4 mg per week subcutaneous dose. The drug is indicated as an adjunct to diet and exercise for adults with an initial BMI of 30 or greater. It is also indicated for BMI of 27 or greater in the presence of at least one weight-related comorbid condition, example, hypertension, type 2 DM, or dyslipidemia. The approval was based on 4 phase 3 clinical trials. Liraglutide. Liraglutide is a GLP-1 analog. It is approved for chronic weight management as an adjunct to diet and exercise in adults with a BMI of 30 or higher, or adults with a BMI of 27 or higher who have at least one weight-related condition, example, hypertension, type 2 DM, or dyslipidemia. The dose for obesity differs from that of liraglutide that is used to treat diabetes. Saxenda is initiated at 0.6 mg subcut once daily for 1 week and is then increased by 0.6 mg per day in weekly intervals until a dose of 3 mg per day is achieved. Approval was based on data from 3 clinical trials that included about 4,800 obese and overweight patients with and without significant weight-related conditions. Orlistat. Orlistat blocks the action of pancreatic lipase, reducing triglyceride digestion and thus absorption. 2 major clinical trials showed sustained weight loss of 9 to 10% over 2 years. Orlistat's effectiveness in producing weight loss does not depend on systemic absorption. The drug may reduce absorption of some fat-soluble vitamins A, D, E, K, and beta-carotene, as well as absorption of some medications. Adverse effects include flatulence, fatty or oily stool, increased defecation, and fecal incontinence. Setmelanotide is a melanocortin-4 agonist. It was approved by the FDA in November 2020 for patients aged 6 years and older for weight control in obesity caused by rare genetic conditions. Example, those caused by POMC, PCSK1, and LEPR deficiencies. Phase 3 clinical trials observe after about 1 year of treatment, weight loss of at least 10% in 80% of patients with obesity caused by POMC or PCSK1 deficiency, and in 45.5% of patients with obesity due to LEPR deficiency. Additionally, improvement was seen in hunger scores from baseline to 1 year. The combination of phentermine and extended-release topiramate, Kismia, was approved by the FDA in July 2012 as an adjunct to a reduced caloric diet and exercise for long-term weight management in individuals with an additional BMI of 30 or higher, or 27 or higher with at least one weight-related comorbid condition, example, hypertension, dyslipidemia, or type 2 DM. The use during pregnancy is contraindicated. Topiramate, which was first licensed as an adjunctive anti-epileptic agent, has been associated with profound weight loss. The amount of weight loss appears to be greater with higher baseline weights. The exact mechanism of this effect is being actively investigated. Although the degree of efficacy is exciting, the propensity for adverse effects, especially CNS effects such as drowsiness, paresthesia, memory loss, and confusion is cause for concern. This combination drug contains an extended release form of topiramate. In addition, the dose of topiramate in this product, 46 mg, is lower than that used for seizure management, usually 200 mg twice daily. Bupropion and naltrexone. This combination is thought to cause a reduction in appetite and increase in energy expenditure by increasing the activity of pro-opiomelanocortin neurons. Bupropion increases dopamine activity in the brain, which appears to lead to a reduction in appetite and increase in energy expenditure by increasing activity of POMC neurons. Naltrexone blocks opioid receptors on the POMC neurons, preventing feedback inhibition of these neurons and further increasing POMC activity. The combination is taken once daily initially, and the dose is gradually increased each week until 2 tablets are taken twice daily by week 4. Drugs for short-term treatment. 4 agents are available in the US for 8 to 12 weeks treatment of obesity. Diethylpropion, phendimetrazine, benzphetamine, and phentermine. Any of these drugs may be used as an adjunct in regime of weight reduction based on caloric restriction in patients with an initial BMI of 30 or higher who have not responded to an appropriate weight-reducing regime. Off-label medications. Several medications that are approved for other conditions also promote weight loss. These include several antidepressants such as SSRI. Others include methylphenidate, not approved by the FDA for obesity management, but several anecdotal reports have described it as having variable success for weight loss. Zonisamide. Guardian colleagues reported that randomized use of the anti-epileptic drug zonisamide in a cohort of 60 obese subjects was associated with a weight loss of about 6% of baseline weight, with few adverse effects. Octreotide. Lustig and colleagues reported the potential utility of octreotide in ameliorating the distinct subclass of hypothalamic obesity. Metformin does not have an indication for obesity, but it is useful in preventing diabetes and improving insulin resistance in conditions such as polycystic ovary syndrome. Its use was associated with weight neutrality or mild weight loss. The first GLP analog, exenatide, although not FDA approved for obesity, it has been associated with modest weight loss in subjects with type 2 DM. A similar effect was seen with liraglutide and long-acting exenatide, which are also not approved for FDA. Higher liraglutide doses of 2.4 mg and 3 mg per day were found to be significantly more effective than orlistat for the management of obesity in non-diabetic patients. The FDA approved liraglutide for obesity in December 2014. Several SSRIs may cause anorexia as one of the major adverse effects. Some of these medications have been used as adjuncts in the medical management of obesity with some success. Fluoxetine, for example, was associated with some weight loss, although this effect appeared to be limited to the acute phase of treatment. Bupropion is licensed for use as an antidepressant and for use in smoking cessation. It was found to be associated with minimal to moderate weight loss in obese patients. Ephedrine and caffeine are second-line options in the medical management of obesity. They both act by increasing energy expenditure, but they are also associated with the potential for tachycardia, hypertension, and palpitations. These medications are associated with greater weight loss when used in combination than when used alone. They cause 25 to 40% of their weight loss by introducing thermogenesis. But they also decrease food intake, which accounts for 60 to 75% of the weight loss effect. Currently, the evidence for the efficacy of these two drugs in promoting weight loss is inconclusive. Cannabinoid receptor antagonists. The central cannabinoid system has an increasingly recognized role in appetite and feeding disorders. In particular, activation of the cannabinoid type 1 (CB1) receptor is associated with increased appetite and appears to be the basis for the effectiveness of dronabinol in enhancing diet in patients with AIDS and other wasting syndromes. CB1 receptor antagonists showed great potential for weight management in several human trials. Rimonabant, the most developed CB1 receptor antagonist, caused a mean weight loss of 3 to 6 kilograms over a 1-year follow-up at doses of 5 to 20 mg per day. Adverse effects, which were most prevalent at high doses, included dizziness, depression, and suicidal ideation, headaches, nausea, vomiting, and diarrhea. The drug was rejected by the FDA because of side effects of depression and suicidal ideation. In Europe, it was approved but later recalled. A Japanese study found evidence that beverages containing high amounts of catechin, a flavonoid found in green tea, may aid in preventing obesity. Patients in the investigation, all of whom had type 2 DM, ingested either 582 mg or 96.3 mg of catechins per day by drinking green tea. By the 12th week, participants receiving the higher catechin dose had undergone a significantly greater reduction in waist circumference than did patients receiving the lower dose. Other potential anti-obesity agents. The increasing knowledge that has come upon the discovery of leptin by Friedman and colleagues in 1994 has spurred a whirlwind of research that has identified several potential pharmaceuticals. However, safety standards for obesity management are necessarily high. Tolerance for adverse effects is limited. Most persons who are obese are fairly healthy in the short term, but the risk for adverse drug effects is enhanced because patients must take anti-obesity medications for extended periods, possibly for the rest of their lives. Agents in early phases of investigation that may yet prove useful against obesity include ghrelin antagonists, alpha-melanocyte stimulating hormone analogs, anthrostatin, neuropeptide YY antagonists, beta-3 adrenergic agonists. With that, we have come to the end of my presentation. These are some of the references that were useful when preparing this talk. You may want to look into them and read further. Thank you for your kind attention, and do subscribe if you found the video useful.